Lateral superior pontine syndrome. It's a syndrome of superior cerebellar artery on the side of lesion. Ataxia of limbs and gait falling to sides of lesion. Side of lesion because of middle and superior cerebral peduncle and superior surface of cerebellum and dentate nucleus involvement. Dizziness, nausea, and vomiting can be due to horizontal nystagmus, can be due to vestibular nucleus involvement. And there can be paralysis of conjugate case, which is on ipsilateral side, due to pontine contralateral case skew deviation. Carnot syndrome features can be there due to sympathetic fibers involvement. Tremors can be there. The location is often unclear. Can be due to dentate nucleus or superior cerebellar peduncle involvement. On the opposite side, there can be impaired pain and thermal sensation of the face, limbs, and trunks due to spinothalamic tract involvement. And impaired touch, vibration, position sense more in the legs than arms can be there with medial lemniscus involvement. Moving on to midbrain syndromes. Medial midbrain syndrome due to paramedian branches of the upper basilar and proximal posterior cerebral artery involvement. This is called Weber syndrome. On the side of lesion, due to third nerve involvement, the eyes are down and out, secondary to unopposed action of the fourth and sixth cranial nerves with dilated and unresponsive pupils. On the side, opposite side, there is paralysis of face, arms, and legs due to corticobulbar and corticospinal tract descending in the crest cerebri. Lateral midbrain syndrome is otherwise called Claudius syndrome due to occlusion of small penetrating arteries arising from the posterior cerebral artery. On the side of lesion, again due to third nerve involvement, the eyes are down and out with dilated unresponsive pupil. On the opposite side, there is hemiataxia, hyperkinesia, or tremors, which can be due to red nucleus and dentatorubothalamic pathway coming from cerebellum.
So at this point, we'll just stop and discuss this once again. So why to know basic anatomy is actually the thing is very complicated because there are so many structures in the brain, especially in the brainstem. But to summarize this, you can just know a few basics. Okay, posterior circulation is very simple. The two vertebral arteries, they join to form the basilar artery and they divide into two branches, right? That's all is the posterior circulation. And to know about the brainstem, it has three parts, the midbrain, the pons, and the medulla. You can classify this entire brainstem as by the rule of four. Like in cerebellum, we say it is the organ of three, right? So the brainstem is the organ of four. So there are three parts, midbrain, pons, and medulla. The four cranial nerves can be divided like the lower four cranial nerves arise from the medulla. Cranial nerves 9 to 12. The next four cranial nerves 5 to 8 start from the pons. And leave off the first two cranial nerves. The third and fourth the cranial nerves start from the midbrain. Okay. But I feel what is more important, and one more point, to tell that the stroke is originating from the brainstem, we call brainstem strokes as crossed syndromes, crossed hemiparesis or crossed hemianesthesia. So what is crossed is, assume that there is a lesion in the right side of the pons or right side of the medulla. Patient will have symptoms pertaining to the cranial nerve involvement or brainstem involvement on that side, and they'll be having weakness or sensory loss on the opposite side. Okay, so a right side brainstem lesion will cause brainstem lesions in the right side, and it will cause sensory or motor symptoms in the opposite side. So that is called crossed hemiplegia or crossed hemianesthesia. So that is one thing. So all brainstem syndromes are called crossed syndromes. Now, how to identify the brainstem syndrome, like which part is involved and whether it is medial or lateral? I'll give you one mnemonic. So I think you can note it down, shared in our group also. So there are four medial structures in the brainstem. That is called as 4M. First M is motor pathway, that is corticospinal tract. Second M is medial lemniscus. So as you know, medial lemniscus is the terminal pathway of dorsal column pathway. So something which mediates fine touch, vibration sense, position sense, and joint sense. The third M is medial longitudinal fasciculus. So, it is a pathway of the conjugate movement of gaze. So, problems with medial longitudinal fasciculus will cause 1.5 syndrome or internuclear ophthalmoplegia. And the fourth M is the medial cranial nerves. Medial cranial nerves, all the motor cranial nerves, 3, 4, 6, and 12. The motor cranial nerves is in the medial part. So the four medial structures are the motor pathway or corticospinal tract, medial lemniscus, medial longitudinal fasciculus, and motor cranial nerves. So why to know this is, if there is a medial lesion, for example, if there is a medial medullary syndrome, okay, if there is a medial medullary syndrome of the right side of the medulla, okay, medial medullary syndrome of the right side of the medulla, what all will be involved? As I told you, there will be brainstem symptoms in the right side, and there will be motor or sensory symptoms in the opposite side. So we'll see the brainstem symptoms in the right side. So which cranial limb originates from the medulla? 9, 10, 11, and 12. But I told you the motor cranial limbs only will be present in the medial side, which means 12th. Right? So 12th nerve will be affected in the right side. That's what they are given. On the side of the lesion, there will be paralysis of one half of the tongue with atrophy. Then I told you motor pathway is also medial, right? But I told you motor symptoms will occur in the opposite side of the lesion. So a right sided medullary lesion will cause paralysis of the opposite side, right? On the opposite side. And what sensations will be lost? I told you medial lemniscus is affected. So medial lemniscus means vibration and positions will be affected in the opposite side. But what will be impaired? What will be intact? Fine touch, touch and pain will be intact, right? So this is how you remember 4M. Motor tract, medial lemniscus, medial longitudinal fasciculus, and medial cranial nerves. Similarly, as there is 4S in the lateral structures. The same thing, if there is a lateral medullary syndrome, okay, lateral medullary syndrome will have 4S. The 4S is, one is spinocerebellar pathway. The spinocerebellar pathway deals with balance. So problems with spinocerebellar pathway will lead to ataxia. The next is the spinothalamic pathway. So spinothalamic pathway deals with pain and temperature sensation and sensory portion of the cranial nerve 5. Third is, and the fourth is a sympathetic pathway. So sympathetic lesion may cause Horner syndrome, etc. Right. So the 4S, which are the lateral structures of the brainstem, are spinocerebellar pathway, spinothalamic pathway, sensory portion of the cranial nerve 5, and sympathetic pathway. So now with this background, if you tell what are the symptoms of lateral medullary syndrome, so the same thing, a right-sided lateral medullary syndrome will cause symptoms of like brainstem symptoms will be affected in the lateral. So what are the things is, sorry, I lost the connection. So what are lateral symptoms will be affected is spinocerebellar pathway. So ataxia will be there. Pain and temperature will be lost in the opposite side. And fifth nerve sensations will be lost on that side. Right. So that is on the side of the lesion, there will be loss of pain, numbness, and impaired sensation over one half of the face because fifth nerve is affected on that side. Then on the opposite side, on that side also ataxia happens, cerebellar symptoms. And because of cerebellum, there will be nystagmus, diplopia, aslopsia, and Horner syndrome. And ninth and 10th nerve will be affected on that side. So there will be taste, loss of taste sensation. And what happens on the other side, there will be hemianesthesia. Right? So only the 3 golden rules in brainstem stroke is, first thing, there will be ipsilateral brainstem symptoms, and there will be contralateral loss of contralateral involvement of the power or sensations. And the 4M, which are the medial structures, motor pathway, motor cranial nerves, medial lemniscus, medial longitudinal fasciculus. Four lateral structures are spinocerebellar pathway, spinothalamic pathway, fifth cranial and sympathetic pathway. Okay, so medial medullary syndrome will have ipsilateral 12th nerve palsy on that side and contralateral hemiplegia. A lateral medullary syndrome will have ipsilateral ataxia, will have ipsilateral nystagmus, the ipsilateral harness syndrome, and there will be contralateral loss of pain and temperature. Same wise, we can frame for everything. For Pontin syndrome, remember 9, 10, 11, and 12 cranial nerves will not be there. We'll be having 5, 6, 7, and 8. So, medial Pontin syndrome, for example, there is no, medial Pontin syndrome, the sixth nerve nucleus will be affected. So, there may be diplopia plus contralateral weakness will be there. Whereas a lateral Pontin syndrome, there will be involvement of the seventh nerve. So, there will be facial palsy with contralateral hemianesthesia. Like that things go. So I think now if you read the same thing again in short, something you can get. Right? The rule of three, remember these three rules in brainstem localization. MCA territory stroke will be very easy because there's not much of structures, only the major structures are involved. So I think Aravind, so just go through the same slides once again and you continue with the MCA territory so that they can follow it now. Okay, once again, I'll mention the four medial structures are motor pathways. So any medial brainstem structures will cause weakness of the opposite side. Medial lemniscus, which is there'll be loss of pain. Sorry, there'll be loss of vibration sense and position sense of the opposite side. Okay, these are sensations. And medial nostril fasciculus will be affected, causing INO. And medial motor cranial nerves, 3, 4, 6, and 12 will be involved in the medial, if the medial part of the brainstem is involved. For lateral, the spinocerebellar pathway will be affected of the same side. The spinothalamic pathway will be affected of the opposite side. Sensory portion of the cranial will be affected of that side, and sympathetic pathway of that side will be affected. Okay, so medial structures will cause only weakness. Lateral structural involvement will cause hemianesthesia. Right. So we'll read through this again and we'll proceed with MCA stroke.
Thanks, sir.
One doubt.
Yeah.
Hello.
Yeah.
Sir, in medial lemniscus, if it is involved, so loss of vibration and proprioception will be on the same
Opposite
side or opposite side?
Opposite side only.
So corticospinal tract, so weakness is also on the opposite side.
That is
loss of
whatever sensory loss, be it
because it is crossed at
spinothalamic
medullary.
sensory
Okay.
loss, be it a spinothalamic sensation, be it a medial lemniscus sensation, or be it upper limb or lower limb weakness, this will be in the opposite side. Only the brainstem symptoms or Horner's syndrome or INO will be in the same side.
Okay.
So to summarize, medial medullary syndrome, as sir mentioned, it's a medial syndrome. So we have the 4 M's. Medulla, so we have 4 cranial nerves, 9 to 12, of which 12 is the only motor cranial nerve. So we have a ipsilateral 12th nerve, 5th nerve involvement, 12th nerve involvement, causing paralysis with atrophy of one of the tongue. Then we have a motor involvement, that is pyramidal tract involvement, causing paralysis of arms and legs on the contralateral side. And then we have a medial longitudinal fasciculus and medial lemniscus involvement, causing sensory loss and impaired tactile and proprioceptive sensation over contralateral side. Similarly, we have lateral medullary syndrome. Since it is a lateral syndrome, we have spinocerebellar tract involvement, causing impairment in the balance on the opposite side. And then we have spinothalamic tract involvement, causing numbness and
balance will be affected on the same side.
Same side. The spinothalamic tract involvement causing numbness and impaired thermal sensation on the opposite side. and fifth cranial nerve involvement causing impaired sensation over one half of the face on the same side. Then we have sympathetic pathway involvement causing Horner syndrome. And
Like
then
inspired pain and
cranial
temperature
nerve
will be
structures.
lost, but the dorsal column sensations will be intact in lateral medullary syndrome because medial lemniscus is not involved.
No. Then we have other cranial nerve findings. We want to, sir, it is difficult to like locate as medial inferior pontine syndrome, lateral inferior pontine syndrome, like that, no, sir. You can grossly tell pontine syndrome, medial or lateral.
Like
Is it not like that, sir?
not very difficult. Like when you do a complete examination, some one or two findings may be missing. Inferior pons will have seventh and eighth, right? Like that. If all the symptoms are present, all the signs are present, then it will be like complete syndrome. Sometimes one or two signs may be missing. So based on which structure is affected, we can tell it is superior or inferior. I think for you, it is adequate if you tell whether it is medial or lateral, whether it is medullary, pontine, or midbrain. That alone will be sufficient.
Medial inferior pontine syndrome. As you all know, it's a medial syndrome. Again, motor, corticobulbar and corticospinal tract involved. So paralysis of face, arms, and legs on the opposite side. Then we have a medial lemniscus involvement. So impaired tactile and proprioceptive sensation over opposite half of the body. Then we have a motor cranial nerve involvement. Sir, some inferior pons, specifically the nucleus per se, motor nucleus per se.
Inferior pons, there's no motor nucleus, right? Seventh and eighth now do not come under motor nucleus, so there will not be motor symptoms.
Yes.
If you tell superior pons, or things, some sixth nerve may come like that. But usually sixth nerve and seventh nerve are close together, so there may be overlap. Seventh nerve is a sensory nerve, so only they are given in lateral inferior pontine syndrome. Seventh nerve is affected, right?
Yes, sir. So in lateral inferior pontine syndrome, again, spinocerebellar tract involvement can cause the ataxia to the same side, and spinothalamic tract involvement can cause pain and impaired thermal sensation on the other half of the body. Fifth cranial nerve involvement can cause impaired sensation over ipsilateral face, and sympathetic pathway involvement can cause Horner syndrome. In addition, involvement of the facial nerve nucleus can cause ipsilateral facial nerve palsy. And in addition, cochlear nucleus involvement can cause deafness and tinnitus. And vestibular nerve nucleus involvement can cause nystagmus, vertigo, vomiting, and ostropsia. Then we have medial midpointine syndrome. Again, on the opposite side, we have paralysis of face and arms due to corticobulbar and corticospinal tract involvement. And again, medial lemniscus involvement can cause impaired proprioception. And pontine nucleus.
Yeah, small things may be there.
Can cause
small things may be there. Yeah, don't get confused with that. If you understand the main gist, that's enough. Because most syndromes you don't see. You see clinically, commonly you see lateral medullary syndrome. You see lateral pontine syndromes. So I think it is enough if you are able to identify that. Some overlap may be there. That's what I'm telling you. Some overlap may be there. But remember this golden rule, most of the things you can localize.
Okay. Medial midbrain syndrome. So on the side of lesion, third nerve nucleus is involved.
And
So,
midbrain syndromes are very, very important. Actually, there are 5 midbrain syndromes. Okay, and 5 are named. It was a question for you in DNB. And
okay, sir.
just to be in short, there are very third nerve nucleus, fourth nerve nucleus, red nucleus. These are some structures which are present in the midbrain. So each of them will cause a different thing. Okay, third nerve involvement will cause separate findings. Fourth nerve involvement will cause separate findings. Red nucleus can cause ataxia. So based on this, some names are there like Claude syndrome, Bernard syndrome,
Yes, sir.
medial. So same thing only, medial syndromes and lateral syndrome. And we have something called as dorsal midbrain syndrome, which is called as Parinot syndrome. Okay, it also has specific findings. It is given by the mnemonic clues. There'll be convergence retraction nystagmus, levator palsy, Upgaze palsy. Okay. Right. So there are 5 syndromes. Remember those 5 syndromes. Okay. So we'll skip this and we'll go to MCA. So why I took so much of time in explaining about brainstem syndromes is like it is commonly kept for the exam. We commonly get confused, which is present. So most of the time in lateral medullary syndrome, by mistake, we tell that patient is having hemiplegia. So it is not right. Okay. Lateral medullary syndrome will cause only hemisensory loss of the opposite side, and it is not hemiplegia. Okay. So please remember there will be crossed syndromes in brainstem involvement, and remember which nerves are present in which part of the brainstem so that they cause symptoms accordingly. And remember the 4M, which is medial, and 4S, which is lateral. So most of the time you can localize it. Even if you are presented with a complicated brainstem case, just by identifying the clinical symptoms properly, you can at least localize to some extent. So try it for any case hereafter if you are seeing in what, so that we'll see whether we are localizing correctly. MCA strokes are very easy. It's straightforward. So we'll continue.
Yes, sir. MCA territory strokes, most often it is embolus than thrombus. There are high leptomeningeal collaterals. MCA origin, if it is occluded, it can cause contralateral hemiplegia, hemianesthesia, homonymous hemiplegia with macula sparing and gaze preference to the ipsilateral side, and dysarthria can be there. So, there is calcarine cortex in the occipital lobe. It is perfused by P2 segment. This is the reason for macular sparing. If central suprasylvian speech area and parieto-occipital cortex of the dominant hemisphere is involved, there will be central aphasia, word deafness, anomia, jargon speech, sensory agraphia, acalculia, alexia, finger agnosia, and right-left confusion. This last 4 features, acalculia, alexia, finger agnosia, and right-left confusion comes under Gerstmann syndrome. And involvement of a parietal operculum, that is central speech area, can cause conduction aphasia. The repetition will be lost. And then a non-dominant parietal lobe lesion can cause apraxagnosia, anosognosia, somatognosia, unilateral neglect, agnosia of the left half of the external space, dressing apraxia, constructional apraxia, distortion of the visual coordinates, inaccurate localization in the half of the field, impaired ability to judge the distance, upside down reading, visual illusions can all be there. Because the frontal controverse eye field or their projective fibers involved, there can be paralysis of conjugate gaze to the opposite side. If the superior division of the MCS include, there can be combination of above sensory and motor weakness and non-fluent aphasia. And if the inferior division of MCS involved fluent aphasia without weakness and contralateral homonymous superior quadrant myopia and hemi-neglect or spatial amnesia can be there. Moving on to
You would have
multiple-stage
understood,
branches.
right? So MCA divides into 2 branches, which is superior division, that is M1, inferior division, which is M2. Superior division supplies the frontal lobe, inferior division supplies the temporal lobe. So Broca's area is present in the inferior part of the frontal lobe, and Wernicke's area is present in the superior part of the temporal lobe. So any occlusion of the M1 will be causing problems in the Broca's area, so they cannot speak properly. It causes non-fluent aphasia. Whereas inferior division or M2 is occluded, there will be problems in the Wernicke's area. So comprehension alone will be affected, which is fluent aphasia. Okay. And frontal area, there will be weakness, motor weakness. When temporal area is affected, it's part of the parietal and temporal lobe. So there will be quadrant anopia, neglect, spatial agnosia, those things. Weakness will not be there in inferior. So most of the time, inferior division of MCA, if it is occluded, patient will present like a psychiatric patient. They'll be speaking themselves, there won't be comprehension. There'll be vision disturbance, there'll be spatial agnosia. Like it won't present with the classical CVA. And a question to Aravind. What are the 6 components of speech, 6 components of language USS, or in short speech?
The comprehension,
Hmm.
fluency, naming,
repetition. And actually speech actually means language. So it also includes reading and writing. Okay. Remember, all these 6 components are tested in MMSC score, right?
Yes, sir.
Yeah, we ask them to name, we ask them to repeat a sentence, we ask them to write, we ask them to read and follow orders, and we ask a question regarding comprehension, and we ask them to do a thing. So all these are tested in MMSC score. So comprehension, fluency, naming, repetition, reading and writing. Okay, continue.
Involvement of lenticular striate branches. It can be a contralateral pure motor involvement, which is seen due to involvement of posterior limb of internal capsule. Again, there can be contralateral ataxic hemiparesis because of posterior limb of internal capsule. There is dysarthria contralateral clumsy syndrome when genu of the internal capsule is involved. And then can be contralateral pure sensory stroke because of ventro-posterolateral nucleus of thalamus getting involved. And there can be contralateral mixed sensory motor involvement because of thalamus and adjacent posterior limb of internal capsule involvement. Opercular syndrome, OPS, or Fox-Chavny-Marie syndrome. Operculum is as depicted in this image. It is the brain cortex covering the insula, inferior frontal, pre and post central, and supramarginal, angular, and superior temporal gyrus. Stroke involving this part is characterized by anorthria and paralysis of the facial, pharyngeal, and masticatory, tongue, and laryngeal and brachial voluntary muscles. Autonomic reflexes and emotional activities of these structures are preserved as spontaneous and emotional controls are provided. On to ACA territory stroke. A1 segment, it's a short segment. Strokes of this segment is usually well tolerated because of collaterals. Involvement of A2 segment, it can cause contralateral motor deficits, predominantly of the lower limb, followed by face and arm weakness. And then can be alien hand syndrome when corpus callosum or frontal lobe or posterolateral parietal lobe gets involved. There can be abulia, there can be agitation, motor perseveration, memory impairments, emotional ability, and incontinence. Bilateral A2 segment involvement can occur, but it is rare. If both the ACA segments arise from a single stem, there can be profound abulia, bilateral pyramidal signs with the parapheresis or quadriparesis and urinary incontinence, though the incidence is rare.
This is actually a question for you. What are the CNS lesions which can cause paraparesis or quadriparesis? It is unpaired ACA. That is a single ACA which is supplying the both ACA territories, which is actually a rare. So for all practical purposes, any paraparesis or quadriparesis is invariably a cord lesion. But if at all someone asks you, what are the brain lesions which can cause quadriparesis or paraparesis, it is unpaired ACA or single ACA stem. So remember, in hemiparesis, usually upper limb weakness will be more than lower limb weakness because MCA is supplying the lateral part of the brain where upper limb representation is there. Whereas in ACA territory lesions, there will be hemiparesis, but lower limb weakness will be more than the upper limb weakness. Okay. There is something called as dense hemiplegia where upper limb and lower limb weakness is nearly the same. It is due to a lesion in the place where it's due to lesion in the thalamus or internal capsule. Okay, so dense hemiplegia is usually upper limb and lower limb weakness same due to internal capsule lesion. In hemiparesis, upper limb weakness is more than lower limb weakness. It is due to MCA lesion. And in ACA lesion, lower limb weakness will be more than upper limb weakness. Not thalamus, internal capsule. Internal capsule or medial part of thalamus. Okay, continue. And one more thing, incontinence, urinary incontinence, fecal incontinence. So the bladder and bowel symptoms will be more with ACA territory than with MCA territory. Okay.
Involvement of the medial surface of the posterior frontal lobe, likely supplementary motor area, can cause contralateral grasp reflex, sucking reflex, Geiger that is involuntary resistant to passive movements, and involvement of cingulate and medial inferior portion of frontal, parietal, and temporal lobes can cause abulia, slowness, delay, intermittent interruption, and lack of spontaneity, whispering, and reflex distractions to sights and sound. Frontal cortex near the leg motor area can sometimes cause impairment of gait and stance, which is gait apraxia. Corpus callosum per se can cause dyspraxia of the left limbs, tactile aphasia in the left lower limbs. Sorry, there's a correction. Anterior choroidal artery. It supplies the posterior limb of internal capsule and the white matter posterolateral to it, through which passes some of the genitocalcarine fibers. Involvement of this artery can cause contralateral hemiplegia, hemianesthesia, and homonymous hemiplegia. The deficits are usually minimum because of rich collaterals. It is usually an in situ thrombosis that is occurring. It is vulnerable to iatrogenic occlusion during surgical clipping of aneurysms arising from the internal carotid artery. Moving on to internal carotid artery, occlusion of internal carotid artery may go unnoticed if the circle of release is competent, because internal carotid artery occlusion usually occurs as a slow progress until which collaterals compensate. If the thrombus propagates, MCA territory is often involved. When origins of both the AC and MCA territory are included, especially at the top of the carotid artery, abulia or stupor can occur with the hemiplegia, hemianesthesia, aphasia, or anosognosia. There's something called fetal PCA, that is where the PCA is underdeveloped. The posterior communicating artery is larger than the proximal PCA, and blood is supplied primarily from the anterior circulation. Ipsilateral ICA occlusion may give rise to posterior circulation like symptoms. Its incidence is 20% if it is unilateral and 5% if it is bilateral. If ophthalmic artery or central retinal artery is involved, amaurosis fugax, blurring of vision in case of blurring of vision can occur. high-pitched prolonged carotid buoy heading to diastole can be seen on auscultation. As the stenosis grows, buoy becomes fainter, is the rule.
So
Common carotid artery.
why to know about these symptoms and all? Is it important to look for carotid bruit or carotid stenosis?
Yes, sir.
Why?
Symptomatic carotid occlusion or stenosis, we can intervene at that stage. So
What
patient
intervention?
like endarterectomy.
Yes, more of surgical management. Okay, so if the intracranial vessels are involved, okay, if the intracranial vessels or the small vessels are involved, then thrombolysis alone may be enough. But in spite, if the patient is having a carotid stenosis or if large vessels are involved, even though the patient improves with thrombolysis, it may be necessary to consider thrombectomy, endovascular thrombectomy, or any endovascular stenting may be planned because all these are large vessel occlusions.
Oh.
Okay.
Common carotid artery involvement, it is more or less similar to internal carotid artery occlusion. Jaw claudication may result from low flow in the external carotid branches. Bilateral common carotid artery occlusion at their origin can occur in Takayasu arteritis. Moving on to posterior cerebral artery, P1 segment. It supplies midbrain, subthalamus, and medial thalamus. Midbrain, as we all discussed, Weber syndromes and Claudius syndromes can occur. Subthalamus involvement can cause a contralateral hemibalismus. There is artery of Percheron, which is a solitary arterial trunk that branches from one of the proximal segments of either PCA. It supplies blood to the paramedian thalami and the rostral midbrain bilaterally. Occlusion often produces paresis of the upward gaze and drowsiness and often abulia. Medial thalamus involvement can cause Dichrein-Rossi syndrome, which consists of contralateral hemisensory loss followed by agonizing, shearing, or burning pain in the affected areas. Bilateral proximal PCA occlusion presents as coma